Today we are going to discuss the commonly used adrenocorticosteroid agents on the medical floor. They include hydrocortisone, prednisolone, methylprednisolone, and dexamethasone. Each agent has got some of the glucocorticoid activity as well as mineralocorticoid activity. However, the ratio or proportion varies. Hydrocortisone is the most natural one and it's got 1:1. It has got the highest mineralocorticoid activity among all these four steroid agents. Also, it has got the shortest duration among these steroids. Prednisolone and methylprednisolone has got 5:1 of glucocorticoid to mineralocorticoid activity, whereas dexamethasone has got 25:1, has got the highest glucocorticoid activity and the lowest mineralocorticoid activity, at the same time having the highest duration of action. Now, we will study some of the factor or some of the precautions we should take while prescribing the steroid agents. Number first is the concept of tapering. When you are considering the use of steroid for more than 2 to 3 weeks, then you should consider tapering. And if it use is less than 2 weeks, then usually we do not do tapering. Why we need tapering? So it is because your exogenous use of steroid suppresses your hypothalamic pituitary adrenal axis, and after long use of steroid, when you stop it suddenly, then your own body is not in a position to produce sufficient amount of steroid agents needed by the body, and your body goes into crisis. So that's why we need tapering before stopping the steroid completely. Now, how should we taper? It varies, but the general concept is here I am discussing how we should taper prednisolone. The dosing is for prednisolone. So if your dose of cumulative dose of prednisolone for a single day is more than 20 mg per day, so we then reduce the dose by 5 to 10 milligram and stay on the same dose for the rest of week. And then after 1 week, then if your cumulative dose is more than 10 milligram, then we reduce it by 2.5 or 5 milligram and stay on the same dose for 1 to 2 weeks, and so on. If your cumulative dose is 5 milligram or more or near it, then we reduce by 1 to 2.5 milligram and stay for 1 to 2 weeks or more on the same dose before stopping completely. Now, another concept is a development of gastric ulcers and GI bleed with the steroid use. And it's because it inhibits the phospholipase A2 enzyme, which is responsible, in fact, the first enzyme in the pathway of prostaglandins production. And in the same pathway down the stream, COX enzyme work, which are the targets for NSAIDs. So both NSAIDs and steroid use are associated with development of gastric ulcers. But when will you prescribe or do PPI, proton pump inhibitors prophylaxis? When you're using steroid with NSAID or there is prior history of peptic ulcer disease or GI bleed, the patient is in critical situation and is admitted in intensive care unit. The patient is on anticoagulant or is having severe comorbidities, then we do consider the use of proton pump inhibitors alongside steroid therapy. Now, another point is prolonged use of steroid is associated with decrease in the activity of osteoblasts and increase in activity of osteoclasts, and ultimately leading to decrease in bone mineral density. So if your use of steroid is more than 3 months, then we prescribe the use of vitamin D and calcium supplement to prevent development of osteoporosis and fractures. Now, its use is also associated with immunosuppression. It do it by decreasing T cell function and also demyelination of neutrophils. We do then prescribe PJP prophylaxis in the form of trimethoprim sulfamethoxazole. So when will we do PJP prophylaxis? If your cumulative prednisolone dose is more than 20 mg per day for more than 4 weeks, or another risk factor, immunosuppression risk factor exists in the form of either hematological malignancy, transplant, additional immunosuppressant like cyclophosphamide use, or prolonged lymphopenia. So in these conditions also we do prescribe PJP prophylaxis for the patient who are on steroids. Now another thing is hyperglycemia. Steroid do have we already mentioned glucocorticoid activity, and it increases the uh, glucose in your blood. So if your patient is on any of the steroid and glycemic control is poor, so you should also consider that steroid do contribute toward derangement of the glycemic control. Also, it causes psychiatric effects including insomnia, agitation, mania, psychosis. So, in a patient who are recently started on the steroid and the patient developed these side effects, so do consider steroid is one of the cause of these psychiatric issues. Also, it do cause changes in differential leukocyte count. It increases neutrophil and decreases the rest of the leukocytes. It increases neutrophil by demyelination and ultimately leading to increase in the neutrophil to lymphocyte ratio. Now, we will consider the uh, these common steroid uses. Hydrocortisone, which I have discussed, having glucocorticoid to mineralocorticoid activity of 1 ratio 1, is most commonly used in two situations, either septic shock or adrenal crisis. Now, in septic shock, we have already mentioned its highest mineralocorticoid activity, and it retains the fluids and salt and leading to increase in the BP and will help you in normalizing the patient vitally. At the same time, it also increases sensitivity of alpha receptors toward your vasopressors and increases the sensitivity or effect of vasopressors. Its dose is usually 200 mg per day, so we give it in 50 milligram 4 times a day. Now, in adrenal crisis, again, its use. It is the most natural steroid. And now coming toward the prednisolone, there are two terms. One is prednisolone, another is prednisone. Prednisone gets converted in liver into prednisolone. So the patient is having liver pathology, so we do not prescribe prednisone. We do prescribe prednisolone, active form. It's usually in oral formulation in the form of 5 mg tablets, either Repicot or Glitacotril. These are the commonly used brand names, and we prescribe it in outpatient for rheumatological diseases and these asthma. Methylprednisolone is in IV form, and it is called the same mineralocorticoid to glucocorticoid activity. Glucocorticoid activity is 5 times higher to its mineralocorticoid activity, and we use it in acute flares of rheumatological disease or even autoimmune conditions, including MS relapse and other condition, including severe asthma when you need IV medication. Uh, Now, also in optic neuritis like condition, we do give IV methylprednisolone. Now, dexamethasone, it's as already mentioned, very high glucocorticoid activity of 25 times higher to its mineralocorticoid activity. So, if it has got very high glucocorticoid activity, it at the same time has got very high chances of suppressing HPA axis compared to the rest of these steroids agents. It is used in brain metastasis or spinal cord metastasis where it reduces the inflammatory effect, the edema, and the compressive effect of these mets on the surrounding area. So it's used in this condition. Alongside, it's also used in the LRTIs, other infection, RDS. Now, having said this, is a one good concept. If a patient is having heart failure, so we try to avoid the use of these steroid agents because every one of them has got certain degree of mineralocorticoid activity and it will lead to retention of the fluid. And fluid retention in a patient's heart failure will exacerbate the things. So now last thing I want to discuss a short topic which is equivalent dose of steroid. So for this it's a formula BPH. B stand for betamethasone or dexamethasone. P for prednisolone or methylprednisolone. H is for hydrocortisone. So 1 milligram of dexa or betamethasone is equivalent to 5 milligram of prednisolone or methylprednisolone, and 1 milligram of dexamethasone is equivalent to 20 milligram of hydrocortisone. So it's a formula like 1 milligram multiplied by 5 is equal to 5 milligram of prednisolone, and 1 multiplied by 20 or is equal to hydrocortisone. So 1 milligram of dexa is equal to 5 milligram of prednisolone, and 1 milligram of dexa is equivalent to 20 milligram of hydrocortisone. So we simply remember it by this way. See you in next video.